So I was thinking that we may be in trouble running this 20 minutes round table regarding how much protection against radiation. Hello there, please, my co-chairman. How much protection is needed against radiation while we operate stones on our patients. So we have only 2 panel members. They are both online. They're guys from here, they are not in the room. So what I have done, just to moderate, I've created a presentation, and I asked the doctors from online. You are the only one, Dr. Chen and Dr. Kushian. How are the radiation side effects categorized generally? Can you tell us very briefly?
I'm Chen Qi from China. In China, we almost every urologist doing the PCNL under ultrasound guidance. Some southern China, they use the X-ray, and while we do ureteroscopy, we rarely use the ultrasound.
Okay.
If we need, we will try to use the ultrasound. But
okay, that is a question, Dr. Chen, for later on. Yes, I think you're right, actually. One of the measures that we can do to reduce radiation exposure is use the ultrasound. But the question goes to, we categorize generally the non-stochastic and stochastic side effects. And the non-stochastic that are dose dependent, we are by far away from the those levels that we are exposed as urologists. But regarding the cancer, there is not such as a dose dependent. They are dose independent. And the DNA injury, you never know when it will occur. So you may have a leukemia if you use radiation for your patients. So I will go to the next question. Do we have any clues? What are the levels of the annual occupation effective dose limits? Dr. Kusiem, Dr. Chen,
yeah.
Dr. Watson, everybody, I mean, anyone
Yeah.
from
Yeah, we have any aggregation for this radiation impact. Because we have not to measure this effect on our area.
Okay. Does anybody else want to make a comment? Well, remember that we should go up to 50 millisievert per year. And if you treat children, I personally do not do children, you have to remember that their exposure should be even lower. So you have also to remember that the whole body is more vulnerable to radiation compared to your eyes. This does not mean, or to your thyroid, but this, of course, does not mean that you should not protect your eyes or your thyroid. Let's go. What is the main principle for radiation protection? What do you think? Either from the panel or from the audience? Of course, the main principle is no radiation, but apart from that? Dr. Chen? What? You are the only one who can actually say no radiation.
Yeah.
When I observe the difference in practice from person to person, there's a huge difference in the amount of time that they have their, in the amount of dose given from operator to operator.
That's absolutely true. And some they don't realize that even a small dose can cause a major effect. That is absolutely true. The main principle is as low as reasonably achievable. Of course, for Dr. Chen, there is no radiation, and I think I'm quite away from having his experience, honestly, to use only the ultrasound. But I've seen Dr. Chen and his colleagues from China, and they are doing absolutely superb job. So, Dr. Chen, I think you made the comment on the use of ultrasound, and I think you are absolutely right. By using the ultrasound, either in combination with fluoroscopy or all alone, all the way through the operation, you certainly reduce the radiation exposure, both to your patient and to yourself. Who do we have to protect, guys? Dr. Watson?
Well, we have to protect our patient, we have to protect our nurses, and least important, ourselves.
Well, I mean, if you ask me, it's not the least important, but we will discuss later on about that. But you're absolutely right.
I'm only saying this because I'm older and my nurses are very much younger and in the age of giving birth.
Yeah, I mean, but anyhow, no one has to be harmed when you are doing a good job. Who to protect? Of course, Dr. Watson is right. We have to protect everybody. The patient comes first, our staff members. But as I will show you at the end, I think our staff members suffer less from the radiation exposure just because of the distance. And of course, we have to protect ourselves. And from where we get our radiation exposure? Dr. Kusiem, from where the radiation comes?
Comes from the C-arm, naturally.
That's true.
Yeah.
But does it come, I mean, of course it comes from the C-arm, but the major problem is not the actual beam that goes down to the patient for us to see, is the scattered radiation that we all get. And as you see, the scattered radiation can go everywhere, and unfortunately you cannot see it. So should we know when we treat a patient? That's a good question, I think. Should we know the patient's previous exposure to radiation when we treat him? What do you think?
Yes, I think I think it's very important to explain the whole operation for the patient, and we ask him for to give us if he agree or no. It's very important, I think, in this way.
I think you are absolutely right, Kicham. We should know what the patient has had in the past, because as you all know, radiation has an additive action to our bodies. So keep that in mind. There are really, we have to justify the need for radiation exposure, and of course we have to do it as more optimal as we can. Now I will skip this because this goes for there are several parameters in your C-arm that you can adjust, and several parameters that you cannot adjust, but we will discuss in 1 minute. So, guys, tell us a few tips and tricks on how we can reduce the dose to the patient. Then it's going to be some tips and tricks how we can reduce the dose to ourselves and then to our staff members.
The first thing I do is to instruct, in my practice, I don't have my foot on the pedal, but the radiographer does, unfortunately. And so I have to teach them and the difference between screen and flash. And intermittent is the way to go. It's rare that you need continual exposure.
I fully agree. Other tips and tricks from the panel or from the audience? Please, yes?
The distance between the patient and the C-arm
okay.
be as less as possible.
Okay.
Yeah, to reduce the scattering radiation.
Of the radiation, correct, Costadine. So other tips and tricks? Anybody else? from the panel?
I think as a doctor, we should rise our experience and the technique to use the less X-ray. Then we can help the patients.
That is true, but when you have to use the X-ray, are there any tips and tricks? Let me I mean, do not magnify. If you magnify, you give, of course, more dose to the patient, and of course, the scattered radiation is higher. I think that it's very important to use pulse fluoroscopy instead of continuous fluoroscopy also, because these expose you to less radiation. I think it's very good to collimate your image, because it's very important not to expose your hand. If your DNA injury will start from your neck, from your body, or from your hand, you never know. So you should collimate your image as better as you can. And actually, if you think we don't need a big screen, and if you do the pulse fluoroscopy and the collimation, we published a study that we showed that we reduced the radiation exposure by 5, and I think this is quite important. Minimize the field overlap. Why I put this slide? Because I think it's very important. I have very good colleagues from Spain. They are doing PCNL with the C-arm rotated in 90 degrees. But if you see, as you see on the right side, or on the left side of the slide, but if you do that, so if you do a lateral radiation exposure, as they do, and we have a lot of conflict and arguments between us, then the bar at the end gives you the radiation exposure. It's sky high. I wouldn't recommend. They say, but we are not sitting at the side of the beam of the CR, but it doesn't matter. The radiation scattering is very high when you use it that way. Of course, you have to do not X-ray, because X-rays expose you to more radiation. Use the last image hold. I think it's very important, and you all do. And of course, do not press the pedal of the C-arm continuously. You can use audible indicators of fluoroscopy, or you can watch actually on the machine the cumulative dose that you are having. But honestly, these two measures in everyday practice we don't use. And I put this slide, Dr. Watson, for what you said, because I think who is going to do it, the urologist or the radiographer? For me, I always want to push my pedal with my own foot, but now and then we may have a radiographer or somebody else other than us. Well, if you see the literature, it really depends on the radiographer, doesn't it? I mean, back in Newcastle, we had excellent radiographers. They did less than we asked for, so I think it's very important. It doesn't matter who is going to do it. It does matter if he is well trained and actually understands exactly what you are planning to do. I think this is very important. To give you an example, if he doesn't know how to put the C-arm on the kidney and he has to screen all the way up, which is a common thing that we see, then the radiation exposure is sky high, and it's a little bit annoying. Radiation protection for the urologist. What do you think, guys? Which is more important? Is it the structural shielding or the mobile or the personal shielding? Or all together? What do you use? Doctor? Yes. What do you do? Dr. Kusiam, what do? You use only the personal apparatus, or you have also mobile shielding in front of you? Because Dr. Chen, he doesn't do radiology, and probably he doesn't use anything.
We For us, we use both. We use both. The two means.
Okay. Dr.
Yeah.
Watson, do you use any other shielding apart from your personal apparatus?
I'm afraid I don't.
Okay.
I'm just working on the dose as much as possible.
Okay.
Anybody use gloves?
Yep, that was the next question, Christian. So I have this nice slide, I think. So why not glasses? I used to use glasses with a side protection also, but I had a lesion in my eye myself, yes. I always use it with, actually for my eye sighting also adjusted, I always use it.
Yeah.
What about gloves? Does anybody use gloves?
Very
Absolutely
difficult,
not.
very
No,
difficult to
no,
do our
no.
procedures with gloves.
Yeah. We
Well,
can't work with.
I say no on the slide, but honestly, it's not entirely correct. For the old type of gloves, the lead gloves that we all knew, we shouldn't use it. It's not only awkward to use it, but somehow they keep radiation inside your hand. But for the new generation, gloves, I think you can use it. There are new types of gloves that you can use it. Of course, not exposing to your hands or your body to radiation is the best way to keep it. And just keep in mind, if you wear an apron, a lead apron, and then you take it off and you just fold it and you put it away, then you are in trouble next time you use it because the lead inside breaks and you are not protected anymore. Once a month, they should be checked upon the radiation protection they give you. Otherwise, you don't know. Last but not least, they give you very good, as you see, very good protection, as you see from the slide, which is quite good. They can cover you from 90 to 95% of exposure. Costantino said about the position of the C-arm, it's very important for the source to be underneath. Yeah. And as Costantino said, you should keep it close to the patient. Otherwise, the scattered radiation is by far more if it is away from the patient's body. Some say, but the patient will be radiated more. That is true, but honestly, you get this approximately the same exposure for the patient and more exposure to yourself if the distance is higher. And that slide confirms. I would say that it's also very important, to define which is best, prone or supine for radiation exposure. Those who promote prone, they have some arguments. Those that they are going for supine, they have some arguments, but I'm not sure if it is a good study saying that it's less or more depending on the position. And of course, I think that the most important issue regarding radiation protection is to limit the fluoroscopy time. If you can stay away, you just put your needle in and you want to check. Make steps 2, backwards, and give the shot for the radiation to see. You don't have to be all the time above the patient. This is a good trick, I would say. And of course, as I said, irradiate only to observe the motion, not all the time, of course, and use last image hold and the instant reply. How many of you measure your exposure to radiation monthly or 3 monthly or whatever? Dr. Watson, do you do it?
No, but I'm going to start on Monday.
Okay. Well, honestly, we didn't use to do it, but for the last, Thano, how many years? For last quite a few years, We used it and we measured. We were always below the threshold, but for cancer, it doesn't give you any currently, believe me, okay? Last but not least, staff protection. Everything we said goes, of course, not for the patient and ourselves, but also for the staff. This slide says that they are less in danger compared to the patient and ourselves, especially because of the distance. They are away from us, and they should stay away from us. We may, for some tips and tricks, we may need a good assistant or the nurse, for those who perform PERT only with their own nurse. But for the rest of the operation, they can move 1.5 meters away or 2 meters away and do the same job again. This is the last slide. What urologists do, we did a survey with Esut and Ulis, and we don't do that well, actually. We work lead apron and a thyroid shield, but not sky high, as you can see. Eyeglasses, very few, Christian. Gloves, very few, and overall, protection shields is 1 out of 2 urologists. I think that, as Dr. Watson said, training is really, really what is making the difference. Training on how to use the CRM, training your radiographer on what exactly you want, training your nurse, training your patient also, that he will be, because patients ask for almost everything, but they have to realize what they are getting with everything and the radiation exposure. And of course, if you see on the survey how many of the almost 300 people that they were asked in the questionnaire, in the survey, how many of them they were aware of the ALARA principle, very disappointing. Only 40% said, we know, not that we just apply ALARA principle to our practice, but we have heard about ALARA. So thank you very much for your attention. I think we should move on.
Could I just ask you a quick question?
Yes, yeah, of course.
Or anybody who knows the answer. Do we have any idea of, here we are, endourologists, and I imagine orthopedic surgeons are in the same bracket. We get a bigger exposure to X-rays than other specialties.
That's a good question.
And wouldn't it be interesting to see what is the incidence of trouble? You know, what a tiny proportion of us will get a cancer, which might be, to see if there's a difference in orthopedic surgeons and endourologists compared to other specialties, dermatology.
Believe me, you asked the right person, but there are not such data. I have really looked at.
No data. Yeah.
There is not a lot, actually.
This would scare us, and then we'd change our practice.
Can I answer that question?
Yes, please.
Dr. S.K. Pal from India. In India, there are about more than 1,000 urologists who are doing PCNL and all these procedures under image intensifier. And we always ask during our annual conferences if anyone knows of anyone member of Urological Society of India who is suffering from radiation-induced problems like cancers or any other. So far, we have not seen any, and we have not noted any member suffering from this particular situation. Only 1 or 2 members have shown their hands and shown their pictures where there is a dermatitis, maybe radiation dermatitis. But no malignancies have been reported in our society.
Well,
I think
sorry to interrupt, for the Greek Urological Association, I know at least one.
Yep.
Okay.
Christian.
Professor Turk.
Just wanted to raise the question, if there's any dosimeter, I don't know, anyone or any that could show us immediately after a particular operation, us as an operator and the patient, how was on a dosimeter range, how was the exposure to X-ray. That would raise the awareness of us and the information for the patient if it was available.
That's a very good question.
Very good.
Well, Christian, I think from Esteban Emiliani that they do have one such a type dosimeter in the operating theater. Also, there is a very good colleague, a radiologist from Bulgaria, that we did 3 very good studies. I'm not sure we discussed that, but she is not also aware of that. I'm not sure. I had some discussion with Esteban from Spain. I'm not sure if it really exists in clinical practice. I don't know. You can have some measurements from the C-arm actually, but this is not the actual radiation dose that comes to you directly. I was thinking that you will go for the cons and not for the pro, but anyhow. Good afternoon. Thank you for being with us.
That's right.
Good afternoon
to everybody.
It's my pleasure.
Well, medical expulsive therapy, we all use it or might use it in particular to provide aid for the spontaneous passage of urethral stones, but it also can be used for other things like to support the frequent passage of the shockwave lithotripsy or to diminuate symptoms for those who suffer from a stent. There are quite a lot of medicines, drugs available for this purpose. And just a few weeks ago, Lim and his working group from Australia published a mini review on this purpose, and they showed the pharmaceutical targets used. And they could show that calcium channel blockers are less effective and have more side effects, and that NSAIDs have no expulsive effect. That's why I just want to concentrate on those 3 drugs highlighted here in red. And start with alpha blockers. Tamsulosin, in particular, this big multi-center randomized double-blind study, placebo-controlled 1-to-1 from China, including 30 centers with 3,450 patients, so a lot of centers. But nevertheless, they could show that tamsulosin, which they used, has a higher expulsion rate for distal urethral stones bigger than 5 millimeters, a shorter time to expulsion, promise less colics, and however, they have more side effects. And it's funny to see, if you look at the table 3 down here in the slide, you might see that the placebo group has some side effects as well, including retrograde ejaculation in 48 patients, so 2.9%. That's just funny to realize that. And I also mentioned the Picard study, which is a negative study. Why I do that, I don't know what Juan is going to tell me afterwards. So I want to already raise this paper because it was a negative paper that didn't show any effect on medical expulsive therapy, but their endpoint was not the passage of the stone. The endpoint was that the patient did not need any further treatment within 4 weeks. A huge randomized meta-analysis of 60 randomized controlled trials, including almost 9,500 patients. That's what I'm showing you next. It's published in 2018 and includes data up to November 2017, yes. And the reason why I like it, they stratified all the alpha blockers. And they also did a very well done bias control. And they could show that the stone expulsion overall using alpha blockers is much higher compared to placebo. And it was true in particular for using tamsulosin in the normal dosage, so with 0.4 milligram per day. In the same study, they also could show that the time to stone expulsion was shorter using alpha blockers, and that there was a lower rehospitalization rate with alpha blockers. However, there were side effects with alpha blockers, not big ones, but minor ones. So that's for alpha blockers, and I want to continue with beta agonists, mirabegron. Just one study just published this year, a few weeks ago. It's a meta-analysis on 4 studies, including 400 patients, showing that mirabegron had a significant effect in improving the stone expulsion rate for patients, for urethral stones, and finally, for those with smaller stones. I thought I misunderstood the paper, and I went back and read it again. But it's expresses verbis, it's smaller stones, less than 5 millimeters, the address to doing best. PDE5 inhibitors, we all know from the treatment of erectile dysfunctions, have been evaluated as well, and that's a comparative study, again, a few weeks ago published. They compared the expulsion rate of tadalafil, tamsulosin, and the placebo group. They could show that tadalafil and tamsulosin improve the expulsion rate and shorten the time until the stone passes compared to placebo group. A meta-analysis of comparative studies on tadalafil comparing with tamsulosin or a combination of that could show that tadalafil as well as tamsulosin are effective, and that even a combination of both might be beneficial, more beneficial, however, than the side effects of tamsulosin apply. Well, that's for the urethral stones, but what's about shockwave lithotripsy and the fragments passage? I want to highlight 2 meta-analyses on that, one from Skolarikos in 2015 and his group. They evaluated quite a lot of different drugs used as medical expulsive therapy, and they could, for most of them, show a beneficial effect, being statistically significant, in particular for the alpha blockers. But nevertheless, they just summarized and concluded that MET might be helpful and can be suggested after shockwave lithotripsy. A Cochrane review done 3 years later, they just included alpha blockers after shockwave lithotripsy. 40 studies included, almost 5,000 patients, and they once more could underline what the first group showed already, that there's a beneficial effect of medical expulsive therapy following shockwave lithotripsy in this study for alpha blockers. What about stent-associated complaints and problems? Does medical expulsive therapy help there? Just want to highlight one paper published last year. It's a systematic review on this topic, including 14 randomized controlled trials, and they evaluated all the information given there based on urethral stent symptom questionnaire, you know, this Canadian questionnaire, or on the IPSS score, and quality of life questionnaires. And the drugs mentioned there and are summarized for alpha blockers and PDE5 inhibitors. And for both of these drugs, the quality of life was improved, in particular in the domains of urinary symptoms, general health, and bodily pain, and not surprisingly, also for sexual health when PDE5 inhibitors were used. Well, quality of life, that's the goal. We want to improve that for our patients. And as I promised you when starting, I said there might be perhaps more attractive alternatives compared to medical expulsive therapy. Indeed, there are. Sexual stimulation helps as well. That's a meta-analysis, including 6 studies, just published a few weeks ago, and they could conclude that sexual stimulation efficiently promotes the expulsion of distal urethral stones and reduce the time to expulsion as well. So I wonder if this helps, and if we had studies in combination with medical expulsive therapy, in particular perhaps with PDE5 inhibitors, if this wasn't an ideal combination, but we don't know. So in summary, MET can be done with different groups of medicines, and it is beneficial for urethral stone patients, might be for bigger stones in the distal ureter, or for mirabegon, perhaps only for the smaller stones. MET might support the clearance of the shock of lithotripsy and reduce stent-related problems. However, MET has some, however minor, but it has side effects, and it has some costs, although they are very low. So I wonder why we should not use them. Thank you.
So thank you very much for your kind invitation to participate in this meeting. It's a pity I cannot be there in person, but COVID has all these things. I just got it 2 weeks ago. I'm still positive. So medical expulsive therapy is a therapeutic strategy complementary to clinical surveillance for the initial management of urethral stones. Basically, is that we give some drugs like alpha blockers and calcium channel blockers, among others, to increase the probability of a spontaneous expulsion of the stone and reduce the time required for this to occur. Some other objectives of this MET treatment are improvement of patients' quality of life and decrease in the need for analgesia, invasive treatments, and costs. As Christian said, more than 97% of urologists have said that they have at some point or at some time used MET treatment. But a spontaneous expulsion of urethral stones occur, and it's very frequent without any help of medication. As a rule, the more distal the stone is located, the more frequent the expulsion can be. And up to 98% of stones that less than 5 millimeters can be spontaneously passed. So we take a look into the literature. I'm not talking about post-shockwave lithotripsy, but indications for MET are uncomplicated urethral stones less than 10 millimeters in diameter. That means that the stone must be diagnosed in advance by an imaging technique. And there are some exclusion criteria, some contraindications. There's a wide list of contraindications for MET, including stones, patients, and drug-related issues. Moreover, both the EAU and AUA guidelines, as well as a systematic review by Schroeder and co-workers, point out that there's a lack of evidence and consensus regarding the optimal scheme for monitoring and timing of the medication. Most of the authors say that look at the results at a month after starting the treatment, while some others do it in a personalized manner, depending on the symptoms of the patient, for example, or they just adapt to the resources. So we have different medications to use as an aid for expulsion of the stones, and one of them is the calcium channel blockers. There are some meta-analysis saying that, for example, Hollingsworth and Sides, saying that calcium channel blockers increases the expulsion up to 65% in the distal ureter and up to 49% when the stone is at any location. But, and here's the study you didn't want me to tell, Christian, is that one of Picard, that a multi-center randomized controlled trial, saying, comparing nifedipine versus tamsulosin and placebo, that they don't find a high expulsion rate of any of both of the drugs employed, and in any other variable of the study. And they don't find even help of these medications depending on the location of the stone, if it's lower, middle, or upper stone, or depending on size, if it's more or less than 5 millimeters. We're talking about randomized control trials, about tamsulosin in this case. There's some studies, one of Picard didn't find any difference in favor of tamsulosin compared to placebo for the expulsion rate of the stones less than 10 millimeters. You will find in red what doesn't work and in green what it works really. Not Picard, neither Picard nor Meltzer found differences based on locations and stone size, comparing tamsulosin to placebo. Purik and colleagues, for example, on the other hand, they found differences. It was better expulsion rate with tamsulosin compared to placebo for those stones in between 5 and 10 millimeters in the distal ureter. And Jay and co-workers found better expulsion rates for stones in between 4 and 7 millimeters compared to placebo, but only in stones bigger than 5 millimeters in the distal ureter. If we talk about silodosin, another alpha blocker, we have better expulsion rate when compared to placebo in stones from 4 to 10 millimeters. Kumar and co-workers also find better results of silodosin when they compare to tamsulosin and tadalafil in distal stones in between 5 and 10 millimeters. And Bayard reports shorter time to expulsion when they compare silodosin to mirabegron in stones less than 10 millimeters at any location. Naftopidil is another alpha blocker we don't normally use. It's more used in Japan, for example. And Cho didn't find differences in the expulsion rate in stones from 3 to 10 millimeters when compared to placebo. On the other hand, Ogaki did find differences when the stones were less than 6 millimeters. What about if we take a look at the meta-analysis? About alpha blockers, Kamsroer made a meta-analysis including 67 studies and found that for stones less than 10 millimeters, there was a global expulsion rate higher than that for that of the patients who were only on analgesia when they used alpha blockers. Some other studies have supported these results afterwards. And Abu Marzouk, another study also mentioned, Christian, analyzing 60 randomized control trials, found no differences in the expulsion rate with alpha blockers compared to placebo in stones in less than 5 millimeters at any ureteral location. When we compare silodosin to tamsulosin in stones less than 10 millimeters, but especially from 5 to 10 millimeters, silodosin seems to have better results in order of expulsion rate, but also have more side effects. So that's why we don't normally use this as the first option. Liu and co-workers reviewed all the possible combinations and dosages they could gather in the literature and compared the expulsion rate of stones less than 10 millimeters versus placebo and time to expulsion versus placebo. They found that the combinations of silodosin plus tadalafil and tamsulosin plus tadalafil plus corticoids were the most efficient. What about in children? Velázquez and co-workers gathered 5 studies, 3 randomized controlled trials and 2 retrospective cohort studies. And for stones less than 10 millimeters, the children had better expulsion rates when using alpha blockers compared to analgesia or no treatment. On the other hand, Siharan and co-workers analyzing 87 studies found no difference in the ureteral stone expulsion rate in children when treated with alpha blockers versus placebo. Finally, in pregnancy, I told you that most of 97% of urologists had previously used MED for adults, but this percentage goes critically down when we talk about pregnant women. It's about 44% the urologists who have used that treatment. And it's because the concern of the fetus itself and the side effects of the medication. Not in vain, alpha blockers and calcium channel blockers can delay the onset of labor. The drugs as first option to use in pregnant women are tamsulosin and alfuzosin. And in the only retrospective study of Tirol and co-workers, they found no differences between in the expulsion rate of alpha blockers versus control, but they didn't find differences in complications either. So this is the last question, the last slide. There are a lot of studies, very heterogeneous, and that means significant design limitations. Lower quality clinical trials included in meta-analysis contribute to heterogeneous results with a low level of evidence. Some of the exclusion criteria, as for example multiple stones, it could be after showy lithotripsy, included in most studies are questionable. The current level of evidence on the benefit of MED in ureteral stones is low, and only the most recent meta-analysis, mostly coming from China, support its effectiveness. And still, 50% of patients prefer the medical over the active treatment. So the big conclusion of this is that MED seems to have a certain role exclusively in stones in between 5 and 10 millimeters located in the distal ureter. So it's clear that we need better quality clinical trials. Thank you very much for your attention.
Thank you, Juan. Are there any questions from the audience? I think, Christian, as we saw in the guidelines in the past, the major issue with the studies, as Juan said, is the quality. If you see, we made back in 2017, something like that, a review on the consort criteria for the randomized controlled trials and the Oxford criteria and the Judged criteria, and the full fulfillment of the criteria within the randomized controlled trials was so disappointingly low. I think the question for both of you is, should we still give a medication off label, Juan and Christian? Because it is off label. It's not on the instructions of the SPC
Yes.
of the drug.
That's true, and I think I was to put on the table, at least in Spanish, off label for this indication, and we have to fill a lot of paperwork if we want to prescribe tamsulosin to a woman, for example. Why should I take this? How can your doctor prescribe this if you have no prostate, they would say. So it's a problem. I think that we need better studies in order to prescribe this medication. And I must say I'm one of those 97% of urologists prescribing this medication for this indication. But I tell you also that since last years, I've been circumscribed to that range of stones in between 5 and 10 millimeters.
Okay, Christian.
Well, thanks for this question. It's off level, and for children, it's off level. Okay. That's the main problem. However, it's used almost worldwide, at least for adults not being pregnant. The studies included what you addressed before. The studies included is randomized controlled trials are usually very small studies, and they are very prone to mislead in their results. That's true. However, the study from the meta-analysis from Abu Mars, so both Juan and myself used for our arguments, they also did a sub-analysis only including studies with low risk of bias, and they could show that's the same result, supporting a positive effect of alpha blockers.
Okay.
It's been a very interesting debate. I'd be very interested to know in what you, the audience, think. Can I just ask you, if you believe in medical expulsive therapy, raise your hand. I'm a believer. And who is not a believer? Oh, we chose the panel badly.
Not anymore. Okay.
Thank you.
Samatelu and the next chairman, Dr. Al-Musafir, to come to the podium. Christian, I Googled your very intriguing and interesting question, whether we have a dosimeter that can actually measure in real time. And active dosimeters, actually, I didn't know that you can get a real-time value of your exposure, and you can instead use an active dosimeter, typically an electronic personal dosimeter. So it exists. I didn't know that.
To be co-chairing together with Professor Al-Musafir this session with all these group of gurus of urolithiasis. So the burning question for this roundtable discussion is therapeutic treatment or prophylaxis? Where should the focus be for the next 50 years? So in order to facilitate the discussion, we have asked the participants to give a 4-minute flash talk each, so as to have plenty, not really plenty, some time after that for discussion. Professor Papachoris has donated his time for discussion. So I would like to ask Professor Goldfarb to take the podium.
I'm only going to talk about the next few years because I'm not going to be working 50 years. I've decided. So it's just going to be a few years. Here are my disclosures. Rogers, where are you? There you are. Okay. Here are my disclosures, and I do want to point out 2 things. One, I do have an interest in prescribing citrate and alkalinizing people, and I do have a past medical history of calcium oxalate stones, and I did not raise my hand in favor or against alpha blockers. Here are 2 papers in urolithiasis. The one at the bottom, written by my friend John Sayer. John, a geneticist in England, wrote about precision medicine in renal stone formers. And I was asked by the editors, including Giovanni Gambaro, to write a rebuttal. And I wrote this paper called Empiric Therapy for Kidney Stones. And my goal here was to suggest that precision therapy, both genetics and 24-hour urine collections, and here the goal of prevention, was actually not necessary. Now, I don't want to be considered anti-intellectual or a Luddite, and opposed to technology and opposed to more modern research efforts. But the truth is that most people with kidney stones in the world today do not see a urologist, do not see a nephrologist, and get no preventive therapy at all. Most of these kidney stones are actually preventable. And yet, as we discussed earlier in the previous session, when we talked about disclosures, there's a significant disparity in the wealthy people who will get treated and get to see a urologist or a nephrologist and someone who gives them some advice, and most people who don't. So my empiric therapy for kidney stone idea is simply that most people are not going to get genetics done. Most people will not have 24-hour urine collections done, and they have no idea what to do about kidney stones. So if we simply, as nephrologists and urologists, prescribed empiric therapy, and by empiric, what I mean is without a further metabolic evaluation without genotyping most of our patients. If we prescribed lifestyle choices and fluids, water, the cheapest possible therapeutic intervention. And when I talk to patients about their water intake, I talk to them as though I'm going to give them cyclophosphamide or rituximab. I'm going to give you the really effective therapy, the cheapest, most effective thing that you can do to prevent kidney stones. Talk about people with diet and citrate, bicarbonate. If you want to use baking soda, whatever you did, if every urologist who saw a patient with kidney stones simply said, take some alkali, this will increase your citrate. It doesn't matter whether your urine citrate is low or not. Citrate is effective for prevention of kidney stones. Currently, we have just gotten this study funded by the National Institutes of Health. Ryan C. is my colleague at Vanderbilt. He's a urologist who trained with Marshall Stoller. And in this study, we will take patients with recurrent calcium stones and randomize them to empiric preventive therapy versus selective preventive therapy. Selective preventive therapy means based on their 24-hour urine collections. All of us talk about 24-hour urine collections as though it's obvious that they're effective, and yet no one has ever done a randomized trial to show that doing that expensive, time-consuming, and unwieldy and inconvenient study, the 24-hour urine collection, is effective. So we will actually randomize patients to treatment based on the 24-hour urine collection. All the patients will have 24-hour urine collections, but half of them will only be advised in a generic way about their fluid intake and their diets. And we'll see whether 24-hour urine makes a collection. I do as many 24-hour urine collections as anyone in the world, I'm sure. And the reality is that I will admit that there is no clear evidence that that is the better way of doing it. And if you thought about all of the patients out there with kidney stones today who get no advice from a urologist, a nephrologist, a dietitian, this is really something we would need to do to prevent kidney stones. So my vote here is certainly for better prophylaxis. Thank you.
I prepared from some slides, but they were thought to enable me sitting in a round to have a free talk. But I can also use them to present them for you, but the layout is not perfect anyway, but I'll try to use them. Therapeutic treatment or prophylaxis, where should we focus the next 50 years? Unfortunately, I'm too old to control myself in 50 years, but it would be of interest anyway. So the first question is looking at this title, what do we mean with therapeutic treatment? Do we mean interventional stone removal, or do we mean to therapy the underlying cause of stone formation? That's the question. And now we know from Goldfarb and others that there are a lot of reasons why the frequency or the incidence of stones might rise. And it's not only the global warming and the so-called urban heat islands, all these things. It's also the population is rising in the whole world. That means also the pollution is rising. And pollution means more carbon monoxide, more carbon dioxide, which both leads to more calcium oxalate monohydrate in plants like the ginkgo. In the ginkgo, that's going back to a study in the 70s. Cadmium as well which is used in agriculture and for fertilizers, might promote stone formation. So there might be more stones even out of this reason. And the environment itself, as we have heard yesterday, also would influence the phenotype of our genes and phenotyping for those genes promoting stone formation. On the other hand, we will have, within the next 50 years, artificial intelligence even more did already start here now. And the science on complex systems will be more and more pronounced, and using all the data we produce. And it's not surprising that, for instance, in our medical school in Vienna, there is an own chair on the science on complex systems. So that's going to raise. What does it mean? We will have more knowledge. We will have more knowledge about particular polygenic stone formation. And as Professor Mizirlis told us today in the morning, there are excessive exosome exosome-based communication between the cells. That means that there will be more interaction with, there's a lot interaction with messenger RNA and the DNA, and that could help us, perhaps, like in the vaccination, like in cancer therapy, to use messenger RNA or nanoparticle or both as vehicles for treatment, or perhaps the CRISPR gene scissors mentioned by somebody yesterday that also could facilitate genetic therapy or individualized targeted therapy for stone formers. Another question is what's going on with the healthcare system? Will there be a great reset? I believe there will be a great reset, not only in the politics and in daily life, but also it might happen that we as urologists not longer exist in this form in 50 years. There might be a specialization based on what we have learned. A specialist for laparoscopy, a specialist on genetic therapy, or what we already know, interventional radiologists. So to summarize and answer the question, in short time, I believe that there will be a development, might still be driven by the companies, might still be driven by technical innovations for stone removal in the near future or today. But in the long-term focus, will be on prophylaxis and causal treatment, including genetic treatment probably, and performed by whomever, not necessarily by urologists. Thank you.
Hello, everybody. I want to tell you something without the backing of slides, but with the backing of your imagination. As a basic scientist, I of course want to do something slightly different. I want to propose a line of research which can answer the question, whatever we try, advice or medication, why when we have this group of patients that we treat, do they all react differently? Well, because we are different intrinsically. And I want to take you back to a paper that Said Khan and myself wrote 20 years ago about the model of how the kidney functions and how this translates to risks for stone formation. You all may know that our kidney increases the risk for stone formation because it does what it should do. It has to reduce about 180 liters of blood per day to 1 to 2 liters of urine. So it has to concentrate. And way longer back, a mechanism was proposed by which our kidneys do this work. They have this osmotic gradient going down the papilla. The countercurrent mechanism is driven by this. It means you start up in the loops with a low osmotic value and you go down with a high osmotic value, and water is sucked out of the nephron through which it passes. Then, writing this study, we also found that this model is based on animal data and on pathology data. We also found people who actually injected kidneys with plastic and counted all the nephrons that were present in those human kidneys and looked at the length of the loop of Henle. And there's a variation in the length, and approximately 15% of the nephrons in the kidneys that they investigated were very long loops, which are most capable of concentrating the urine. And in our mind, of Said Khan and myself, these are the most at risk nephrons where crystallization can start. Now, as anything in biology, also the distribution of these long loops will differ from person to person. So in these kidneys, about 15% were long loops, but there may be people who have 30% long loops, and there may be people who have 5% long loops. We don't know. So ever since I was thinking about this, and it kept sitting in the back of my mind, until Several years ago, I read papers about new developments in a field apart from us, MRI, and they are capable of measuring sodium concentration in living tissue, and they did studies on humans, on the kidney, visualizing the osmotic gradient in those kidneys, and showing that if you give the subject in the MRI machine loop diuretics, you see a change in the osmotic values in the gradient. So I propose that for the coming 10, 20 years, it would be very exciting to see whether, first of all, people differ in the gradient that they have in their kidneys. Second of all, is there some relation with stone formation? And third of all, how do these gradients react to all the medicine that we already know of? And can we develop new medicine based on this information? And then the next thing to this forgotten role of kidney structure is that we also found that when nephrons exit from the papilla, the duct of Bellini, it doesn't go out like a straight tube, as you might expect. Many of those ducts have a strange kink, more than 90 degrees. And you can imagine that in order for a plug to get stuck, it's much easier to get stuck where you hit such a kink than when you go flush out straight. So that's also something, if you are capable of viewing the presence of such structural differences and correlating this with stone formation, it will open up a whole new field of research which people younger than us hopefully can pursue.
I am not the last, but almost the last. So most of the things that I wanted to say to you were just proposed by our panelists. Basically, what I think is that speaking for recurrent stone former or for a young stone former or for children who form stone, what I think we must do is to go toward the precision or personalized medicine, because we need to tailor the disease to personalize the prevention or the treatment. So what we must take into account is the genetic, the microbiome, to better evaluate environment and lifestyle. So we have two sides of the problem. On the side on the right of the slide, to genotype the patients. This is now is affordable. Just now, you can a panel of 20 gen are easy, affordable, and they will become very, very cheaper along the time. So we will be able to diagnose, as I pointed out yesterday, 34 monogenic disease, but you have to remember that the first genetic disease was discovered in only 20 years ago. In 20 years, we have found 34 genes, and I feel that in our 20 years, this number will be double or more. So many genetic disease could be diagnosed in a precise way, and probably we will have also specific treatment. On the other hand, we must simplify the genotyping of the patient, because 24-hour urine are at the moment the gold standard, but they are a little bit difficult on the practical side. So I am very confident on the development of method to have a very precise stone analysis based on endoscopic imaging and radiological imaging, more than conventional stone analysis, but could offer also information on the morphology of the stone. That is a plus, because give us more information and allow us to identify some precise diagnosis. And the other point is to increase the point of care diagnosis of metabolic defect, evaluation samples in the morning, or even using strip to evaluate the most important defect. Obviously, we have also the problem that in parallel with recurrent stones in which we need to improve the diagnosis, we will have a huge number of patients that will come from climatic change and from dietary change. This group of patients could be treated more conservatively because probably the number will increase more and more, and it is not a problem of knowledge, it is a problem of public health in order to start with primary prevention. Thank you.
All right, ladies and gentlemen, my position regarding ring stone disease in the future, say 2070, is that of a Greek temple supported by 4 pillars, whose name is climate change, water pollution, planet overpopulation, and war crisis. And no matter how smart our engineers will be to fix new things, develop new drugs, we'll have got to fix that first. And that's a position I'm going to take today in parallel to what Professor Türk just said. So let me take the first one, climate change. Yesterday and today we talked about it. We mentioned that the rise in temperature would lead people to sweat more, male and maybe female as well. I don't know, you decide, all right? And this will lead to drop in urine volume, increase in stone, provided people cannot follow with water. And that's exactly the point, because the rise in temperature will also lead to a decrease in access to water. Yesterday we talked about the melting of the glaciers, of course, but we didn't talk about the drying out of the lakes, which is a current problem, which will decrease the access to water and force people to buy bottled water. And this has been developed yesterday and today. There will be a discrepancy between poor people who cannot afford that and the rich people who just buy bottled water. That's one point I want to say. Next one, water pollution. At the time when capitalism is actually governing our lives, the idea to have a world which is entirely bio, but that's a dream. We'll constantly have companies developing new toxic elements in order to foster agriculture. These substances will infiltrate water, and infiltrating water will decrease access to water. And the same process is going to happen. And Professor Türk talked about that in the fertilizers. How about planet overpopulation? Well, according to me, planet overpopulation is leading to drop of agriculture surface areas, because actually every day we are building new towers, every day we are building new soccer stadium, and this is at the cost of the agriculture areas. And what is the consequence of that? The drop in production of dairy products, meat and poultry, fruit and vegetable, and this is going to impact the tendency to urinary crystallization. You see, you may have increase in promoters like oxalate with the first one, a decrease in promoters like urate with the second one, a decrease in inhibitors with the third one. You understand my color code at that point. What is in red means fostering stone disease, and what is in green is the opposite. And how about war? Well, the war crisis, unfortunately, we know more about it right now. I mean, have two consequences major. One is a flare-up of the prices from petrol to food. And this has a consequence. We'll have a decrease in consumption of meat, fish, and poultry, fruit, and vegetable, and again will impact the urinary crystallization factors the same way as before. But not only that, war crises are going to decrease the agriculture areas. The war in Ukraine actually has taught us that the bombing of the fields is currently a major problem, destroying the sources of grain. Source of grain means decreased production of grain, and you can imagine a drop in urinary inhibitors like magnesium as a consequence of that. Well, all in all, ladies and gentlemen, I think that the future of renal stone disease will be an imbalance between promotion and inhibition. Promotion leading to stone disease. And now the question which has been up for debate is what can we change? So, of course, the strategy is, first of all, this is the point I wanted to make, fix the four columns first, or think about it. Otherwise, we have been discussing now empiric citrate administration, on empiric magnesium prescription. Why not? I think this at some point will be necessary to consider. RNA interference therapy, drug development. Well, we have to convince the pharmaceutical companies to get engaged into that, which is not easy because of actually the poor extent of the market for some of these situations. But anyway, we have been talking about pioglitazone, hydroxycitrate, the nanoparticles, enzyme degradation products. Well, this is the nice thing to do, but that's what I wanted to bring you to launch the discussion. Thank you.
Now, can I just ask if any of the members of the panel would like to comment on somebody else's position, or please, go ahead. Thank you, Dirk.
Yeah, I would like to comment to your presentation. I want to, regarding the effect of war, I think that the effects of war somehow can be mitigated by lifestyle changes. And as proof of this, I would like to point you to publications that most of you will not know about what happened in Sicily during World War II, before and after the American army arrived there. Before they had, so this was someone looking at renal stones. Before the Americans arrived there, the population had few stones, but they were infection stones. Then the American army arrived, started to deal out army rations, a lot of protein, and then 1 year later, in Sicily, the people got calcium oxalate stones. So, there may be something positive when a war happens, because it forces the people to change their affluent lifestyle, if the war is in an affluent area, to a lifestyle that is less risky for them. But then when they revert to the peaceful situation, which I hope for them, it would be better for them to remain in the new lifestyle without the overconsumption. And then the second point is about the shortage of water. I see that as a technical problem related to energy. There's so much water present on this planet, but it's salt. And we have already the techniques to convert salt water to distilled water, but it takes energy. So the technical problem to solve is to have enough energy to produce water from sea to drink.
I have a comment. I think that the problem should be split in 2 points. As a scientist, what we can do is to work on recurrent stones. And in this field, we can do much by increasing genotyping, by increasing phenotyping. The other side of the problem is a problem that is not for scientists, is a problem of public health. We can solve the problem of global warming, we cannot solve the problem of agriculture, and I feel that we can also only offer some information, but the problem is of the government, is not a problem of scientists. We can offer knowledge, no more.
I'll say one thing about genetics. Although I like to think of myself as a geneticist for kidney stones, and we have a couple of databases that we work on, the genome-wide association studies for kidney stones specifically have really been negative. And so although twin studies demonstrate that kidney stones are highly heritable, the genome-wide association studies are essentially negative. So like diabetes and hypertension, where these are heritable disorders, the likelihood is that there are 1,000 genes that are responsible for diabetes, for hypertension, for kidney stones. And most of the things, the diseases that we're talking about, are not going to turn out to be monogenic disorders like primary hyperoxaluria or cystinuria. And so I am very interested in the genetics, but I'm not very sure that it will help most of the population with kidney stones.
The problem, I think that the problem is better phenotyping, because genome-wide association studies were made by geneticists. They don't look to stone, they look to stone disease. It is quite a mistake. We have two phenotypes, and probably we'll have more success. So it's a problem of methodology.
Okay, thank you very much. And as a conclusion of this session, we have a lot of questions that we are not answering. Why a stone when it is small and it is as a crystal, not flushed with the urine and comes outside? This is one. And if we don't know the exact pathogenesis of the stone, how would we prevent the stone? No one hypothesis explain why the stone is formed. This is a second question. And the third question, what about the prevalence and the incidence of the stones after COVID-19? Is it affecting the incidence of the stone, or there might be a lot of cases after this era or not? So I think these are points for investigations, and at the same time, we should develop and progress in the treatment of the stones, like, for example, new drugs or in minimally invasive techniques. And all of us know about the peptic ulcer. It was a surgical disease, and now it is a medical disease. We maybe the stone in the future, in the 50 or 20 years ago, might be a medical disease. Thank you very much.
Thank you very much. Oh, yes, Professor, please. Yes, you can have that. It's over there.
I just wanted to say, especially in response to Professor Trinchieri, because of course I knew in advance that there would be a gap between positions dealing with science and positions dealing with public health. I took this position on purpose because the chairman who wrote to me to ask to make a presentation made, and you have seen here, has written 50 years. 50 years means 2070. So what I wanted to stimulate in the audience is that don't look at what's going to happen in 5 years. Think about what's going to happen when none of us
is going to be present, you see. And that's my fear, is that it will be a complete different world, and it might be a good idea to think about.
If I can make a closing remark, I think that no matter where science wants to take us, it will be public health systems that will take us. It will be healthcare systems that will drive the way. And it will be the scarcity of resources. It will be the lack of doctors, sometimes lack of materials, that will have to point towards prophylaxis, towards prevention. Which means that maybe we have to focus on prevention and send our knowledge towards the direction of internists, of general practitioners, and make sure that they can implement a few things just before the patient even comes to our hands. I'd like to thank all the panelists for their valuable contribution, and since time is pressing, go ahead to the next table.